Thank you again for joining us tonight for this special webinar Wednesday. Tonight we're going to focus on a topic that is near and dear to my heart, MS and family planning. So thank you for being here tonight. This webinar series is brought to you by Can Do MS, and my name is Krista Sipp. I'm the Director of Programs here at Can Do. As always, I'd like to thank our generous sponsors for their support of this program. This is a special webinar being supported by Viatris. And now I am very excited to welcome our speakers tonight. We have Can Do MS's lead senior programs consultant here. We have Dr. Roz Kalb. Many of you are familiar with Roz. She's a psychologist and a health coach here at Can Do MS, and she's been working with people and care partners with MS for over 40 years. So we're excited to have her here to help lead the conversation. And then along with Roz tonight, we have a special guest, Dr. Riley Beauvais, who we are very thrilled to welcome. So welcome tonight, Riley. Riley's a practicing neurologist and scientist at UCSF in California. And Riley is a leader in sex and gender aspects of neurology, publishing, collaborating, and lecturing on this topic. So we are very lucky to have her tonight to talk about family planning and MS. Riley, you have such a robust resume, so if there's anything else that you'd like to chime in and share with people about your background or interests, we'd welcome that. But again, thank you, Riley and Roz, for being here tonight. We appreciate this meaningful presentation and look forward to hearing from you. So without further ado, I'll hand things over to our speakers, and here we go.
Thanks very much, Krista. You know, it's been quite a few years since I've had the chance to work with you, Riley, and I'm really excited to have you here. As Krista mentioned, Riley is both a practicing neurologist and a clinician scientist, and that's just a magical combination. So we're very fortunate to have her as we zero in today about women's and men's MS care during the perinatal period. But before we dive into those details, Riley, can you just tell us what got you interested in this aspect of MS care?
Yeah, hi, it's just a pleasure to be here and to be working with you again, Roz. In terms of what has gotten me excited about this, I think when we think of who is affected by MS and, you know, MS starting in people's 20s, 30s, 40s, and people sort of be thinking about their families or adding on to their families or not wanting a family. I think these are places where this is, you know, there's a real need for clinical guidance and clinical care. And so that's been one of the really compelling things for me. In addition, I think we know that there hasn't been enough attention to women's health in general. So women have not, you know, there hasn't been enough research in women's health. There hasn't been enough attention to sort of reproductive safety of medications, and people haven't always been heard. And so I think we're really seeing in society healthcare finally catching up and saying we need to listen to everybody, a man, woman, male, female, and we need to have care that really is really sort of catered to who they are as an individual, to their biological sex, to their gendered roles in society, and just supporting the whole person. So it's really exciting to see this movement, and I think we're kind of trying to catch up with science to be able to sort of provide updated, you know, evidence-based guidance here.
So tonight, this is just a preview of what I'm going to be talking with Riley about. So we're going to talk about pregnancy planning or prevention as an essential aspect of caring for young women and men with MS. We're going to talk about hormonal immune suppression during pregnancy and how that works and what happens following the end of a pregnancy. Riley's going to talk about disease control through that whole pregnancy period and how they do that. She also talks about what she refers to as the fourth trimester, which is all those issues that happen after birth and how that's such a critical period in the MS course. And we're going to talk about the genetic risks, because any potential parent that I've ever worked with has asked the question about the risks for their children. So this is just a preview of the topics. And now I'm going to ask Riley to say, okay, so what are your key messages? Where do you start and when do you start talking with your younger patients about decision-making around reproduction?
Yeah, I think the counseling starts with diagnosis. So, if I have a young person who's being diagnosed, I think the key message is really that you can plan for the family that you would want if you did not have MS. So I think a lot of people worry about what their future is going to look like, and maybe they're not ready to make any new decisions. But I just want them to move forward with their diagnosis and with their medication decision making, knowing that it's really about sort of just supporting them through their decision making. I think there's also a concern that the MS will somehow adversely affect children. And I think, you touched on the genetics of that, Roz, that really their MS is, and we'll go into this a little more, it is a complex genetic condition, but there isn't a high risk of MS in someone's children. But also other things that even if there is some disability in the parent, that doesn't mean that the children will not develop sort of intellectually or physically or any which way. We really do need to pay attention, of course, to things like the parent's mental health and sort of financial planning, things like that. And then just that as, a neurology care team, we're going to work with the patient, with the individual, and with their OB fertility team to manage MS during childbearing. So it's not time where we just send you away and off you go. It's really, we work together. And, thanks to really the work of many, we're able to really both provide better evidence and also see that people make different choices. And so if we could just advance slightly, there's one more figure that's going to pop up, and it really shows that basically across the world, what we've seen is that after a diagnosis, we're seeing both men and women decide to have children in greater numbers. So we're not seeing that people are we're basically seeing that people are probably getting reassured by the data that we have, and they're therefore more and more choosing to have children. So that's kind of where we start. And again, you can see kind of numbers increasing over time. This is a Scandinavian study. And so I think it does start absolutely at diagnosis, and we, and then we have to revisit, because of course people change their mind. Someone who's newly diagnosed, may not be ready to have a family, or, they may not be in the right relationship. And so we revisit every time. But of course, there are medications that we have to think about pregnancy plans when we decide what medications we're going to recommend. We have to make sure that the person's getting all their vaccines that they might want during a pregnancy, that they might need during a pregnancy, before we go ahead and affect their immune system. And if the person does not want to have a pregnancy, we have to think about preventing the pregnancy until they're ready to do it safely. And so these are all things that we revisit every visit.
So if I'm understanding you correctly, you bring this up at the time of diagnosis, even if the woman you're talking to, or maybe even the man you're talking to, doesn't bring it up. Because,
yes.
Okay.
I do. And you know what? I'll tell you something. If I have young adults diagnosed, often they come with their parents. And when I say this, you can plan for the family that you'd want if you didn't have MS, usually that's where the parent tears up. Because I think it's on the back of people's minds, even when they don't bring it up. And so I think it's important to lay it out on the table and say, hey, if we get there, we will work on this together. And this is something that we can do together. But I think that's an important message for people. So it's not lingering in the back of their mind and them changing their life choices because of misinformation.
So if you're talking to a young couple who are of childbearing age, and the mom the potential mom or dad
Mhm.
has MS.
Mhm.
My guess is that the two people in the couple may have very different reactions, or sometimes have very different reactions to what you're telling them.
Mhm.
For example, one might be gung-ho and excited to hear that this can all go the way they wanted and ready to jump in to parenthood,
Mhm.
where the other partner might be thinking, "Oh, I'm frightened. There's too much unpredictability in the future. I'm not ready for this." Do you see those um, concerns being aired within a couple when they're sitting with you?
I do, and I think my goal is that those concerns be those that would come up between a couple kind of anyway.
Right.
So, so I want to put on the table the fact that we have to pay attention to the invisible symptoms of MS. So that we have to make sure that the person who would be going through the pregnancy, if it's the female who has MS, we want to make sure that they are that we've optimized their mood as best we can, that we are paying attention to fatigue, social supports, things like that. And we want to have a frank discussion about what we know about the medication safety, and I know we'll go into that later today. But I think my goal is that we sort of put on the map that we can cross that bridge and that we can do so together and just try to get alignment on some of those key things. Yeah.
So I do know that sometimes in my work with couples, when they're talking about their excitement, but also their worries about becoming parents, one of the questions that I often heard was, "Well, how can I do this? How can I be a good mom or be a good dad if I have MS?" And
Mhm.
what I discovered over time in talking to these couples is that they're picturing either wanting to be parented exactly the way they were parented as children, or the opposite of the way
Mhm.
they were parented. But
Mhm.
they have a very strong view of what good parenting means. And so
Mhm.
one of the tasks of working through these worries is to remind people that good parenting at its foundation is providing love and
Mhm.
security and safety
Mhm.
for your children to grow. And you can do that standing up, you can do that sitting down, you can do that in all kinds of ways, as long as you are prepared to think creatively, keep your
Mhm.
sense of humor, just like all parents have to do,
Mhm.
and assume that you'll know how to love and parent your child or children when they're there.
Mhm. I think that's so important, and this. I think it's also an opportunity to shine the light on men with MS who are defining themselves as fathers. And I think, certainly, sort of, whereas gender is very societally constructed, the 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 you American sort of image of the guy with the Chevy playing football with his kid type thing. I think it's so that's such one version of parenting. And there's so many ways, as you said, to show up as a parent, really being present and emotionally present for the children just seems to be the key thing. And, I just love what you said. You can do that sitting, standing, any which way.
Any which
Mhm.
way. So let's
Mhm.
jump to one of the biggest topics on
Mhm.
people's minds, which is how they're going to manage their MS at the same time that they're guaranteeing the health and safety of the child that they want to conceive. So how does that work?
Yeah. So what we know about MS is we know that during pregnancy, the risk of MS relapses, MS attacks really quiets down, and then there can be a rebound postpartum. But we also know that when we're kind of tinkering with the medications, stopping the medications in anticipation of pregnancy, et cetera, we could be, someone could be off their meds a while they're trying to get pregnant, et cetera. And so I think there's really two schools of thought about this. Do we want to be proactive? Meaning, do we want to just say, hey, we may be using our heavy guns, but we just want to quiet this MS down from beginning to end of, the whole childbearing episode so that you can really focus on other things. And this approach is really preventing injury before it happens. And what I found is when we do that, when we know that our patients are really going to be kind of steady during this whole time period, then that emotional energy focuses on other things like focusing on pregnancy planning, connection, rehabilitation, all the other things that someone has to do. And so I've really seen from a sort of overall confidence in, life perspective, active management can be really positive. And so this really involves just optimizing the DMT or disease modifying therapy or MS therapy window before, during, and after pregnancy. But you could also say, hey, and this would be sort of the, slide advance, the reactive, management, which is, hey, maybe not everybody needs to be on such effective therapies. Maybe not everyone needs the big guns. And maybe, we should just sort of be, less is more and minimizing risk and things like that. And so in that situation, what you might do is, not everybody wants to be on an MS therapy, period. And so in that situation, what you might do is say, okay, well, we're not going to really lean in on the medication, and we're just going to really use MRI to monitor activity. And I would say in that case, not everybody needs the big guns for sure, but then you really want an MRI close to conception so that you know what the MS looked like, so that if there's any new symptoms during or after pregnancy, you can respond. And so I think those, that's the reactive management. And I'm just going to be very clear that my bias is proactive because I think it's really important. Like, I just see how much better people feel when they're not worried about sort of like this unknown. Pregnancy is already so stressful and so much work. But certainly you can make a good argument for both sides, I think, here.
So I think I understand, and I'm pretty sure all of our audience does, the difference between the proactive management and the reactive as you've described it. But do the medications themselves, and we now have, 20 plus treatment options, doesn't each one of those medications have information about pregnancy and breastfeeding, and does that information that has to be approved by the FDA to be included in each drug's label, does that information help you as a provider in making decisions about medication use during this time?
Yeah, I think that's a great question because I think it's really important that we know, like, what perspective, what lens are we using when we think about medication safety? So the first lens should be the guidance just from the FDA, or if someone's in Europe, the European Medicines Agency, the EMA. Like, what does the label show? And I have a couple examples of just like why that can be quite confusing. But certainly in some areas, people just have to practice according to labels, and so that's one way. A second approach to medication, sort of discontinue, whether you stop or stay on or continue the medications or how long you wait, is this 5 maximal half-lives approach. And that's basically, if you want no drug on board at the time of conception, then you wait 5 half-lives of the drug before conceiving, between stopping and conceiving. There's some problems with that approach. So one is there's some medications, mainly teriflunomide or Aubagio, which you need to actually do accelerated washout or wait 2 years. There's some medications where when you stop them, you're exposing not just that the MS becomes active again, it's that their MS rebounds big time. And so that's specifically the S1P receptor modulators, so Gilenya, or natalizumab or Tisabri. Those medications, if you stop them before pregnancy, you can have a very severe rebound relapse. And those medications, I often opt to bridge people off of them instead of just stopping them. And then the third fact, sorry, go ahead.
Before you jump into the third one, can you just explain for our folks what a half-life is and how that can vary from one drug to another so they know what kind of time frame you're talking about?
Yeah. So some drugs very quickly are eliminated from our bodies from the kidney, by the kidney or the liver, and some drugs that can just be a day or two. And so some of the medications like Copaxone or like Tecfidera, medications like that, they're actually quite quickly eliminated. Other medications linger in our bodies for a very long time. And Aubagio is an example where there can be a really big tail end, and it has historically been considered not safe with pregnancy. And so, and then sort of somewhere in between are the medications, the infusion medications, the monoclonal antibodies, like the B-cell depleting therapies or Tisabri. And those medications, a half-life is somewhere 20, 30 days. And so 5 half-lives would be 3, 4 months. And so really, if you want no drug on board, right? So you wait 5 half-lives. So every half-life is the amount it takes for half the drug to be eliminated. So you go to a half and then a quarter, until there's none left.
Awesome. Thank you.
Mm-hmm.
Okay, I interrupted you before
Yeah.
the third part of
The
your
last, yeah, which is again sort of where I'm a little biased, Roz. Like I'm a little biased towards trying to just make the best, most informed decisions we can in shared decision making, thinking about what we know about a medication, what we know about the class of medications, and what's important to the patient and their family, loved ones. And I think that's kind of where a lot of medicine is, right? For any condition at any time point. But especially here, we have to navigate really prioritizing what we think is best for the patient and for the eventual baby. So this is kind of the real world situation. And thankfully, we're getting more real world data to kind of guide us here. Okay,
But
those
how
are 3 frameworks.
fortunate it is for young couples to have a clinician like you who takes the time to think about not only the data from the medication label, but as you say, the real world data, the class effects of the drug, but also what's going on with that particular patient. Not everybody takes the time to do that.
Well, this is sort of one of the most wonderful times in, someone's life. And I think that's how we show up, you know. I think if we don't do that, then what we're going to do is avoid risk and keep people maybe on low efficacy medication because we're afraid of risk. And that's not serving the patient or their loved ones in the end. Mm-hmm.
So I believe you were going to show now some of the reasons why just going by the label isn't always helpful.
Yeah. So this is a bit of a busy slide. So and most of it is not, doesn't need to be reviewed. I just want to highlight a couple things. The top yellow rows are data around pregnancy, and the bottom rows are around lactation or breastfeeding. And what you can see is I've selected just B-cell depleting medications. So these are all quite similar medications. They have their differences, but they all basically are monoclonal antibodies that deplete B cells, and they have similar half-lives. And what you can see in the columns is what the FDA says and what the European equivalent, the EMA, says. And if you just pick, let's say, ocrelizumab, so the FDA says wait 6 months, but the EMA says wait 12 months. So even for the same drug, the labels are inconsistent. And then if you look what the FDA says for all the different medications, for some it's 12 and for some it's 6. And the EMA, for some it's 12, for some it's 6, for some it's 4. And so just to try to highlight, like if you were just going by the labels, you would not be necessarily making the best medical physiologic sense. And so that's where we haven't been served really well. But then care teams and patients are navigating, the real world bit, without that good, strong guidance.
So when you talk to couples about your recommendations for treatment and the high efficacy versus moderate efficacy and your priorities for their care, do you find that couples are always in agreement? about the risks they're willing to take or not take? Or do you find that sometimes there's some stress between them about how much risk they're willing to take?
Yeah, it's actually been I would say quite positive that when you have information and real data, I think that it's a lot easier for people to align. And just to point out a few things, this is a picture that we had in a recent review where a lot of the people who've been doing a lot of work in pregnancy space kind of came together internationally to try to have some guidance. And we were talking about the risks of treatment stopping versus continuing, and the benefits of treatment starting versus stopping versus continuing. And we were thinking about it from the perspective of the mother and the baby and ultimately the family. And I think, it's important to name all of those perspectives, right? So, and then it's important to kind of prioritize, I think, a little bit based on what we know. And so just to hone in on like one box here. So let's just hone in on the top right box. So what would be the risks of stopping medication? We typically say that stopping medication is the safest option. Just stop everything, right? But for the baby, if the mother, has a relapse, let's say we stop Tisabri and she has a big flare, that's not going to be great for the baby, actually, to have the mother get worse, right? She'll be emotionally stressed, she'll have physical disability, and she may need rescue treatment. That's not necessarily serving the baby, right? And so I think that's an example of where we think that what's best for the baby is just sort of like peel back all meds all the time, and that's not necessarily true. And so I'd like to kind of put all the things on the table and then kind of hear priorities. And certainly some people just want no drug on board when they're conceiving. And other people want no risk of disease activity and give me the one that's the safest for the baby that's going to guarantee that. And so there's really, a lot of factors that go into this.
How lucky we are that there are so many drug options available so that you can have those conversations and try to meet the couple where they are in terms of their priorities. We're very, very fortunate in MS to have that.
And Roz, because that's probably a place where you do a lot of support and guidance and counseling, do you have any kind of, clues for us in terms of how to explore those feelings and preferences? How do you help people with that?
It sounds like you really do it, and that a couple looking at this slide, for example, would see that that everybody is being considered, right? The baby, the mother, the family. I think sometimes that so much attention is focused on the mom, right? And her MS and her priorities, that sometimes the prospective father is sitting there quietly scared to death. What if my partner's MS suddenly gets worse? What if something bad happens to the baby? And I just think they need the opportunity to air their concerns, to be heard, so that they feel like they're part of the decision as well. Because they sometimes don't speak up, right? They don't share how scared they may be about the unpredictability of MS or about the health of the baby.
Yeah.
Before we move on from decisions about DMTs, let's just focus for a minute on men who have MS, because there are some considerations for them and their treatment as well. Could you talk to that?
Yeah, so I think it's so important. I think, one of the big things that you raised earlier is just sort of the perspective of how one sees oneself as a parent, and that we really want to sort of acknowledge sort of the gendered experience of men. But there is a few sex differences in risk and course. So we know, MS is 3 times more common in females than males. And we've historically said that men may progress at a slightly faster rate, but what we see sort of in the era where people are put on really effective therapies is I don't see that as such a marked difference. In fact, I think one area where men have really been neglected in our society is around mental health. And I'd be curious, your perspective on that. So I'll, not go too much into that. But I think, just thinking about social support and, naming mental health. One thing that I like to remind people is that sometimes in men, depression is expressed as irritability. And that I think is important to put on the table as well. When we think about specific symptoms and concerns that might come up around, sexual function in general or around sort of kind of conception, is what is the libido? Are there specific difficulties, with erectile function, or is there mostly sort of, maybe depression, fatigue, libido difficulties? Some men ask about, testosterone supplements, things like that. And we really just keep scratching the surface of that issue. We don't have good data for people. And then again, I think that sort of societal role, like how do you see yourself as a parent? Is it all about, playing ball, or is it also about connecting? And then I think there's a little bit, we don't know much about the medications specifically, and what they, what their safety is. Mostly we say that men in general don't have impaired fertility, that their fertility is pretty, as in the general population. But, they should get support if there is erectile dysfunction or difficulty with orgasm. And then most of the medications we say, that we haven't really looked at the impact on sperm. The two kind of caveats, one is Aubagio or teriflunomide. That's been found in women whose husbands are taking it. And so men would want to use barrier contraception or wait 2 years after stopping treatment before conceiving. And then cladribine, Mavenclad. And for that, men would want to use contraception for about 6 months after the medication. Those are the two kind of, side notes. But typically we tell men that, I think a lot of it is actually sort of being present for men sort of in terms of their mental health and well-being. And so I don't know if you have a perspective on that, Rob.
Well, I do, but it would probably take more than tonight's program to cover that. But I'm really glad you mentioned the mental health issues, because I think one of the things we know in our culture is that it's easier for women generally than it is for men to talk about their own emotional needs, or their need for support, or fears around something like starting a family, which is a major social and personal transition that can cause a lot of anxiety around finances and parenting and everything else. So I think we all, as clinicians, but also as women who are partners to these men, we need to be very sensitive to the feelings that they may be having and not comfortably sharing. And making sure that men who are suddenly prickly or irritable or withdrawn or remote, that we ask, how are you doing? How's your mood? Do you think maybe you need some help right now? So thank you for bringing that up. So I think we want to talk a little bit now about gender inclusivity, which is a hot topic these days, and again, it could be a whole webinar unto itself. But what's your recommendations for as a clinician and for your patients around these issues?
Yeah. I think in general, what we know is that there's a need for more inclusivity and better guidance, but we don't have good information on how to do that yet. And so I think the key thing is just really having a clinician, a team who is, culturally aware enough to know that we need to be inclusive and to think about these concerns, and also to just partner and try to do the best we can with the limited information we have. So I think there's a couple things there. Certainly when I talk to other clinicians, I talk about, we don't want to, don't always assume that the female patient in the room would be the one who's having the pregnancy. Maybe it's their female partner. Don't always assume that a sort of person, male presenting partner is biologically male. Some people may want to have a pregnancy on their own. And so we have to really be open to sort of the really broad expressions of, sexual preference and also gender identity. There's a couple key things that we have to think about. One is some people may take gender affirming hormones or have surgeries, and that could affect sort of like, let's say someone who's had breast reduction, that could affect ability to breastfeed, things like that. It may also affect people's sensitivity around things being called breastfeeding. They may prefer more neutral terms like chest feeding, things like that. And then, what happens if your clinician is avoiding learning about your your health and biology is they may not know the body parts, right? Like they may be like, well, I don't know, I'm kind of confused about this person's gender identity, so I'm just going to not go there at all. And so then they may be missing opportunities to provide really good guidance around pregnancy or guidance around, bladder, bowel, sexual function, all these things. And so I think you just need to get a clinician who is willing to go there and to ask questions and to think together.
So a quick question that I hadn't actually anticipated asking you, but since you've said that, so there's somebody in our audience, perhaps, who is dealing with these issues and wants to find the kind of provider you're talking about. How would they even begin to look for somebody like yourself, for example, who is very open to talking about these areas and also very knowledgeable? How would they go about looking?
I think there's more and more neurologists who are interested and knowledgeable. And so certainly like at UCSF, we do one-time consults for people if they want more specialized care, and maybe we don't know the answers, but we'll try. And I think also just sort of, looking more and more MS centers, and this is really wonderful. I'm seeing a lot of more junior doctors who are kind of, really interested in these themes and want to get more training and be better at these themes. And so I think just like you would ask your doctor for a one-time consult for, an immune lab abnormality or a liver lab abnormality, you could ask your main neurologist for a one-time consult for someone who's really going to go there to give guidance during pregnancy or gender affirming transitions or things like that. And I think that, people hopefully are feeling more empowered to ask for the things that they need. So I would, certainly in our center, we really advertise how important it is for us. And I think certainly an MS specialist, for one, is mentioned by someone in the chat, but maybe an MS specialist who's really wants to give good guidance in these areas would be key here. Even if times one, just save up your questions. Ask them all.
And if you're talking to a prospective provider, it's okay to advocate for yourself and for your needs and say, this is something that's on my mind. Is it something you would be comfortable helping me with? And hope that the provider would be honest enough to say, absolutely, this is in my wheelhouse. I'm happy to help you with this. Or no, I'm really not an expert in those areas, and I'm going to find somebody to refer you to. So we've taken slightly less than 9 months to get through conception and pregnancy. We've got a baby safely delivered. So now let's talk about the postpartum period. So
yeah, so postpartum. So this is kind of where I like to call it the fourth trimester. So the fourth trimester, there's a lot going on in the fourth trimester. And historically, kind of like patients went off, they delivered their baby, call me if you have issues, and then they come back at some point and you've missed a massive window to make a difference and to be there for your patient. And so I think there's a couple key things we have to think about. The first is that people are at higher risk of relapses in the postpartum period. And so historically, we've said a quarter to a third of all women could have a relapse postpartum. And when we look at brain MRIs, even up to 50% of women can have new brain lesions postpartum. So what predicts that? How do we prevent that? So we know that stopping the high efficacy medications, of course, is leaving the MS up to its own, business. And certainly how active the MS was before pregnancy. So if the person had a higher disability score, EDSS score before pregnancy, if they had more lesions on their MRI, that's going to predict postpartum relapse to some extent. We also know that breastfeeding is protective. So exclusive breastfeeding in the first few months is protective for a little time window. Not forever, but while the patient is breastfeeding exclusively. And we also know that starting therapy back early, first few weeks, highly effective therapies that have quick onset, that is protective. It can really abrogate disease activity or just really reduce that disease activity. And so therefore you'd think, well, then if breastfeeding is good and meds are good, so can we do both? And, we haven't known, like historically, people were just like, well, avoid, do no harm, we shouldn't know. And in the last 5 years, we've really been trying to push the field here and say, actually, it's very important. We're doing harm by not treating our patients. At no other point in MS would I accept that 50% of my patients are going to have new brain lesions. Like I would never accept that, right? So why are we accepting it now? And so we've been really trying to actually understand the safety of the medications. And there's kind of a way you can do that without exposing the baby to risk. If you think about it, at the point where the mom is weaning, so when she's already decided she's not going to breastfeed, that's when you can treat the mom, look for drug. And if there is no drug, you're like, well, maybe let's get more samples. And then you've kind of de-risked it a little bit because you've seen that there isn't much drug transfer. And then you can get more samples and do the proper studies. And we've been able to do that with a lot of the monoclonal antibodies, the medications that are given. And we've actually been able to see that there's much less drug transfer than you'd expect. And so there's a kind of a currency, like a measure called the relative infant dose. And that kind of tells you how much the baby would get compared to the mom. And the relative infant dose for a lot of the medications is very, very low. And then you have to think, if it's a medication that's not even a pill, so that's not even well absorbed through the gut, you have to think, well, maybe then even if there's a bit of drug in the milk, the baby is not going to absorb it. And so we've been able to kind of move the field a lot, and we've been able to see that a lot of the medications, certainly the monoclonal antibodies, so the B-cell depleting therapies, Tisabri, medications like that, there's very little in breast milk. Similarly, those first-line soft injectables, so the Copaxones, glatiramer's, as well as the interferons, there's very little in breast milk. They're not considered as effective, but they're not, going into breast milk. So that's been something that I think has been really kind of important because it can provide patients reassurance that treating the mom, preventing injury, is not going to necessarily do anything negative to the baby.
So for your own patients at this point, Riley, are you having them on some treatment that the data have shown to be safe after birth when they are breastfeeding?
Well, some still choose not to, but I do recommend in general starting a higher efficacy medication about 2 weeks after delivery. The medications that I know don't go into breast milk. So, the first week or two, you're just trying to get out of the hospital and get a sense of what has gone on, physically, and start lactation. And you have colostrum, and that is much more sort of smaller quantities, more precious, more, all these things. But after, maybe 2 weeks later, when you've seen the lactation consultant and then milk is considered mature, that's when I think, that's where our data start basically.
So what are you seeing then in terms of the postpartum relapses that we used to hear so much about with combination of breastfeeding and being back on medication? Those numbers must have changed dramatically.
They go away. They go
Awesome.
away. So if we
Awesome.
if we get someone, not everybody, it's not magic, and it's not a cure, of course, but if we can get people treated about 2 weeks after delivery, we don't see relapses.
That's fantastic.
Hmm.
That's good news for
Hmm.
everybody. Okay,
Yeah.
so let's move on to what you call the fourth trimester. We all know that while everybody's focused on getting pregnant and then carrying the baby and then delivering the baby, that real life really starts once that baby's there, okay? And you're home and you're living with MS and a new baby. And so what are your thoughts about what has to happen during that fourth trimester?
Yeah. So try to start that planning around 7 months of pregnancy. So because we know that parental leave in the US is just so bad, so short. We know that parental leave, even of 3 months, is just so hard for someone who also has a chronic condition. And so um, I find that if I don't have the stuff I need authorized and scheduled, once the baby arrives, the likelihood that that will happen becomes much, much, much less, right? So we're really talking about comprehensive care on multiple fronts. We're talking about first preventing disease activity. And so we've talked about a lot of those things, lactation, a lactation plan. If the person is uh, sort of like selecting more reactive management, getting an MRI scheduled, and then just making sure that thyroids and things like that are, screened for. But then we want to think of just the person from head to toe. And so we know that in general, there is somewhere around a 10-15% risk of peripartum, baby blues or postpartum depression, mood, depression, anxiety. And patients with MS are a higher risk of depression in general and anxiety in general. And certainly we see that in the postpartum period. We also see a lot of fatigue, a lot of sleep disruption, and then people, sort of pregnancy brain, mommy brain can be, disruptive. And so the screening for that mental health is really in the clinic, in the neurology clinic, also in the OB clinic, also in the pediatric clinic. We really need to be comprehensive there. Then thinking about the physical, so gait, balance, endurance, falls. We did a study at UCSF where we found that of all of our patients postpartum, about 75% of them had physical therapy amenable symptoms, so things that could get better with PT. Only about a third of them were referred to PT, and only a third of those went to PT, including patients who fell in the postpartum period. And imagine having a new baby and falling, right? So we need to do better from that. And I kind of I'm a little bit of bossy, and I really try to get my patients to like schedule that PT. And then it's like, if you don't need it, you can just cancel it. But you won't schedule it, once the baby arrives. Similarly, pelvic floor physical therapy, because of course there can be a lot of difficulties with bladder from MS and from childbearing. And then just thinking about the social support, social stressors. Do we need to get social work involved? And, like kind of writing prescriptions for things like uninterrupted sleep, someone to come in and take care of the baby for a couple hours for a nap, things like that. Really comprehensive, I think, is the key messaging here.
So we're getting short on time, but I really want to talk about the perinatal depression and emphasize that for our listeners, because the risk goes up pretty high for women with MS postpartum, correct?
Yeah, the risk increases. And in fact, what we know is that actually in the postpartum period, women with neurological conditions are more likely to be hospitalized, rehospitalized for anything at 30 days, at 90 days, and they're more likely to have severe maternal health outcomes. And it's not like most of our patients just do very, very well. So I don't want to be alarmist, okay? But I do think that we need to really be careful about people's well-being. And one key thing that we can do a lot about is mental health. When we looked in our clinic, so the Scandinavian group and a couple others have found this increased risk of depression, anxiety, postpartum. And when we looked in our group, what we found, some of the risk factors were basically the same as the general population. It was just that our patients had that more. And so that was people who were slightly older age at their birth, or their first birth or primiparity, and people who had prior depression. And that's kind of like what's been described in the general population. We didn't see that MS factors played a really strong role here, but the MS does play a role in sort of predisposing to depression risk in general. And so really there's so many treatments that work, even just acknowledging the difficulty, acknowledging the burden of everything that someone is going through, whether they're the mom or the dad who has a new baby. There's just so much stuff that they have to adjust to. And then, there are medications that have been approved specifically for peripartum depression. So, it's treatable and it's so important for the baby. This is one of the key areas that really, peripartum mental health affects children lifelong. And so this is a key area where we can make a big difference.
And just a word from the psychologist here, and that is that for any women with MS or men who don't want to take yet another pill, we know that cognitive behavior therapy and other mind-based therapies can be just as effective for depression. So we don't want you to think that getting treated for depression necessarily means you have to take more medication. One more question we really have to answer, and that is everybody's questions about the risk for their baby of getting MS. So can you talk about this?
Yeah, absolutely. So I think the bottom line is the bottom line on the slide, which is we don't have a test right now that can determine whether a child will develop MS. What we know is if a parent has MS, their child will have somewhere a 3-4% risk of developing MS. We know that even in identical twins, if one twin has it, the other one, there's only a 25% chance they'll have it. And so, yes, even with identical genes, the environment matters a lot. What do we know about the environment? We know that a few things are like bad. So, smoking is probably bad, and exposure to Epstein-Barr virus, the virus that causes infectious mono, contributes to sort of MS risk. Beyond that, we don't know so much. And so, I think if a person said, well, is the potential risk to my child of getting MS so bad that I should not have a baby? I would say no, because the risk is really quite low.
And what we know as parents, you and I, is that the risks of other things happening to our kids along the way are much, much, much higher. So
Yes.
yeah, everybody go ahead and have your babies without being too concerned about that. This is the summary of what we talked about, but I want to make sure that if there are questions that have come in, that Riley has at least a few minutes to respond to them.
Absolutely. So I decided to come on screen. I saw a really great question in the Q&A box, and that is, are there recommendations for resources for brand new parents? So, okay, now we've gotten here, we have a new babe at home. Are there resources for brand new disabled parents with MS? Any suggestions when it comes to that? I am also going to flip to this slide. If we don't get to your question tonight, please email us. Riley, I'm going to kick it to you. Any resources for new parents that are disabled?
I think that is a fantastic question. I think there are a lot of, so the short answer is no. In MS, we don't have a specific sort of like place to look for that. I would look in the spinal cord injury literature, and I will certainly work with Krista and Roz to identify some of those resources, because I think it's a critically important question that we have not paid enough attention to, and certainly around what kind of sort of sit-to-stand devices or things like that might make it easier to handle a baby. Those kinds of questions I think are really critical. So the short answer is, I don't know if you have ideas, Roz.
So if you just Google resources for new parents with a disability, several different resources come up. The American Psychological Association has resources for parents with disabilities, and the parent training and information centers and community parent resource centers all offer resources for new parents with disabilities. So just a quick search will give you some good resources.
I'm just gonna chime in as well as a thought. I mean, at Can Do, we talk so much about the multidisciplinary team. I think that different team members can probably offer resources in parenting, whether it's sit to stand holding a child, positioning, etc. I feel like maybe an occupational therapist could be beneficial to talk about.
I agree.
So definitely don't hesitate to rely on your healthcare team members and ask for referrals from your neurologists. And like Riley said, I'll be bugging her for some follow-up resources to help the new parents that do have MS get off the ground with some resources as well. Again, I want to call out this info at cando-ms.org. If we did not have the chance to get to your question tonight, please email us. So I've got Riley's email address. We can follow up with her. We can follow up with Roz. We have some MS specialists that we can tap depending on what your question is. We'd be happy to help you guys with any family planning or parenting questions that you have. Thank you all for being here tonight. Thank you to Roz and Riley for this conversation and for sharing information with us on family planning and MS. Thank you to Viatris for their sponsorship of this program, for making tonight possible. And most of all, I want to thank all of you for being here. Thank you to our listeners. We are thrilled that you are here and that you are going on this family planning journey. And we're excited for you and what the future holds. So definitely don't hesitate to reach out if you have questions tonight, or if you're looking for any other resources. Thank you all for being here, and happy Webinar Wednesday. Have a wonderful night.